Thank you very much for the invitation. I've been in post for about 3 months, and I'm just approaching the dangerous phase of thinking I understand what's happening. My measure of success for this talk is the number of people who say, gosh, there's something there that we need to share with England, whether it's a new product, a new way of delivering healthcare, collaboration on a data set, a process that you've worked out that we could use. So for me, what's interesting is what happens afterwards. We have a stand here from UK Trade and Investment, and anyone who'd like to come and discuss any of these things either today or tomorrow or by email, please do. I'm going to have to spend some time telling you around the setting, because I understand that some things in healthcare might be a little different. But before that, I think that computerization only ever does 2 things for healthcare. The first is it improves patient safety, and that's nearly always by removing discontinuities. And you heard about those earlier, about care of an individual patient with cancer. And those discontinuities occur within our organizations, and they occur across organizations. And we're in a really interesting setting in the National Health Service in England, where we can be very joined up, and we need to use the information systems to do even better at that. And you've also heard about waste. Most of the waste is about wasting staff time. So this is the setting that I come from. The National Health Service in England, and for this bit, it's different between England, Scotland, Wales, and Northern Ireland. And I understand that I am in Boston, and I do have to make that bit clear. And what we're really proud of is our general practice. Let me get all the words. General practice, family doctors, primary healthcare physicians. And we have all of these in one organization in the NHS, nearly 8,000 of those. To most of our patients' surprise, these are actually self-employed doctors working in partnerships, but it looks as if they just work for the National Health Service. And if you're a patient in England, you have a general practitioner, and we have universal coverage, and everyone has a general practitioner, and care is totally free. So I did hear some words I didn't really understand earlier today, such as insurance and plans and employers. We don't have that complexity. We have a health service. We have 161 hospitals managed by the same organization. We're also responsible for mental health, which I think is pronounced behavioral health, community providers, and we run the ambulance services. And the expenditure on that went up quite a lot by our standards to reach the sum of $3,000 per person per year, which I think is about half of your expenditure, but it all comes together. So we're in a great opportunity to redeploy some of those resources. And the bit that's new, the NHS was formed in 1948, but the 1st of April this year, we formed NHS England, where I now work. This is a completely new organization. There was nothing like it before. And what this does, it receives $160 billion a year from the Department of Health. That's from taxpayers' money. And it funds everything that happens in the National Health Service. We're not the Department of Health. We're deliberately created as a non-political arm's-length body. We receive the funds, and we receive a letter called the mandate that gives us the priority areas for expenditure for the next year. But it doesn't detail where any of this money has to go at all. We get the money, and we get some very light instructions. And then we go out and commission within the NHS. So there's part of the NHS buying from other parts of the NHS. The top bit is our general practitioners who are funded through a national contract to negotiate it every year. It's the same for all general practitioners, no matter where they work. The second part is the bit that's really changed this year. The money for hospitals, for all secondary care, goes to the local general practitioners who are formed into 200 clinical commissioning groups. So these are people who spend most of their time looking after their patients, but a small amount of their time deciding what to buy from the local hospitals. And they have complete freedom to buy from this NHS hospital or that NHS hospital or a private supplier, or to keep the money themselves and to provide the health care that last year went into a hospital to come out of primary care this year. We've never tried anything like this before, and we don't think anywhere in the world has tried this for 50 million patients. And then 10% of the money we keep for specialized tertiary quaternary care, because that's not appropriate to be decided locally. In our setting, social care is funded completely separately. So the new bit out of that is the second bullet point, the really exciting opportunity of giving the money for hospital care to be distributed by the local general practitioners. What are the starting points in terms of their clinical information systems? Our general practitioners have had fully computerized medical records, many of them for over 20 years. That's every patient in England, every general practitioner in England, every office practice in England. It's fully computerized with the physicians doing direct entry into these systems. And they just take it for granted. We're nearly a generation on now. People don't say, gosh, that's interesting. They just go and do that. They do this with vertical market systems that are not used anywhere else. They have some communication capacity. So for laboratory reports across the whole of England, every laboratory, every report, every general practice receives those reports computer to computer with no human intervention. We want to see lots more flows going that way. And all of those patients are registered on and off the national system with no human intervention. But even with that, within the practice, they're still spending time scanning documents came from the local hospital, and these systems aren't used by all the primary care staff, which now includes nurses, midwives. We have a 100% midwife system, physical therapists, occupational therapists working out in the community. But then when I get to hospitals, the clinical information systems they have, you would actually recognize as being very similar, and some of them are the same. We have several Cerner systems. We have our first Epic system in Cambridge, England. And they all do the really basic functions. Patient registration, laboratories, all reports, and nearly all requests, and all the radiologies have PACS systems. We don't have a billing layer in our systems because we don't need one. And then, if you go into hospital, you'll see a great variation between the different clinical departments. So most intensive care units, most renal units would be highly computerized, but many emergency departments, acute medicine areas wouldn't be. And the systems have the same issues that you do. Is it better to have a big single system or to have lots of really good systems that communicate with each other? And then they do some communication with national systems, but not as much as they should. And I classify these systems according to this, but someone else classifies them by a European model, and then someone else has an American model or a Canadian model. These are the HIMSS data. It'd be nice if we were a bit more mature by using the same language. This is the most reassuring slide I've got, because on the right-hand side, it includes the US figures for uptake of these functions according to HIMSS. And that's where I can say, within the hospitals, it's very similar what you have at the moment and what we have at the moment. What are the weaknesses of these? They're the same systems. We probably have the same weaknesses. They're designed around organizations at a time when we want the care of patients to flow across organizations. They're inflexible in managing those changes. Some people have problems with data standards. We don't know what really works. And their knowledge management isn't great. And then behind the scenes, as a national health service, we have some national systems. So we have all the demographics, all the patients in England on a national system, who they are, where they live, who their general practitioner is, and we have a unique single function patient number, the NHS number, to identify them across all the processes. We also have a summary care record. That's who you are, allergies and alerts, who your general practitioner is. But it doesn't have a full medical record attached to it. And that's a really interesting point about how much you should put into the national system. And then we aggregate activity and measure it in the same way that you do. And from that starting point, in a new job, I go out and talk to clinicians, and this is what they tell me. It doesn't feel very modern compared to what they have when they go home, or when they want to communicate with someone on the other side of the world, or when they want to book an airline ticket. It somehow doesn't seem to be as good as the best of those. And then it's not joined up, that something is known in general practice, but when they're seen in hospital, it isn't known anymore. The systems don't quite meet their needs. It sort of enables you to request the investigations you want, but it isn't easy to do it in the setting they're working in. And then as the doctors move from place to place, of course, they tell you that others do it better. And then we have this really interesting question. With 100% use of computerized records in primary care, what is it that the GPs did that was right to give them this unique thing of 100% computerization and 100% use by the practitioners? Then my new organization tells me this is nothing to do with informatics. This is the big messages I get from my commissioning body. Make it safer and spend less money. But I did start out, those are the 2 points that computerization can do for you. And then a theme I've heard during this week's visit to the States, provide care closer to home. Things you used to only do in hospital, do them in primary care. Things you only used to do in primary care, do them in the patient's home. Things that used to take a nurse in the patient's home, get the patient to do themselves. The big message, I think, for these times. And if we do that, can we avoid unplanned admissions of the elderly patients as they deteriorate? Can we detect that earlier and intervene at a time when it's clinically better and organizationally cheaper? Can we use third sector, voluntary, charities, relatives, to provide some more elements of the care? And then, can we do things for long-term conditions, not the elective surgery, but all of those elderly patients, 80% of 80-year-olds have at least 2 chronic conditions. What sort of architecture of healthcare delivery and architecture of information systems makes that better? And then the same theme I've heard several times today, can we improve our accountability and transparency to patients? And people who implement real systems give me this list. And I won't go through them because I'm sure all of your eyes have picked the one that you had most recently. We have all of these problems as you try and computerize. There's one at the bottom, which is some problems that we had with a government-developed and delivered IT system. But I understand that doesn't happen over here. Yeah. And then we have these barriers, but I don't want to spend a lot of time on the barriers because I really want to get onto the opportunities. It is hard to identify cash reliefs and savings early in the process of computerization. I'm going to give you some positive messages about the last 5 yards to the bedside. Let's move on to the opportunities. Well, we're running a campaign since I started to make sure there's a Chief Clinical Information Officer, and you can read Chief Medical Information Officer, Chief Nursing Information Officer in every one of our hospitals and in every one of our new bodies, the clinical commissioning groups, because these are the people who can communicate between the technologists and the practitioners and pass the messages in both directions. We have this fantastic opportunity from young practitioners. These are the people who applied to university online, did their modules online, got their results online, got their hospital jobs allocated to them online. They then spend their first day on the ward and they say, what's a clipboard? Yeah? Now they'll accommodate it pretty quickly. If you don't listen to them in the first few weeks, they'll just do it the way the organization wants. But if we listen to them as they arrive, they will tell us how to do this better because they've seen it in other domains. Similarly, we've got practitioners who've worked over here and come over there and say very politely they do it better. And we've got the opportunity from enabled patients. The opportunities from technology are obvious because they're sitting in front of all of you. I'm only interested in cloud services because they can persuade hospitals that the real business of information management is not in running the servers. They just need to get out of that business completely and get closer to the patients. I don't hear as much mention as I'd like about auto-identification, barcodes, RFID, the things that have made such an enormous difference in logistics and retail. I don't see much of that in healthcare, and there's a really interesting demonstration outside of using face recognition technology. And of course, we want the back office clinical information systems to be better. So these are the big projects we're running from the center in order to do that. GP systems of choice, the next generation of these successful GP systems with full paperless communication between primary and secondary care, not just laboratory reports, everything working seamlessly between the systems. The second one is the Technology Challenge Fund. We're announcing this week allocation of the first $400 million to hospitals to lift their systems infrastructure, and we have another $1 billion to come next year. And when we go out to the hospitals and say, we'll match your capital in this area, what do you want? The things they're saying at the moment are computerized medicine management, prescription for the doctors, administration for the nurses, and computerized document management, which surprised me. Even the people who have big EMRs want a document management system as well, and every hospital wants a portal. We have another fund specifically on technology for nurses who I think tend to get left out of some of this. And in digital primary care, two at the bottom look quite small, but our digital primary care program will open up the patient records on the general practice primary care systems to every patient in England by 2015. An enormous enabling project. And then just 8 letters at the bottom, care.data, we will build an aggregated analytics system that has all the activity from a whole country, 50 million people, from primary care, secondary care, and social care, all mashed together, available to anybody who wants it. And that includes new entrants to the market, competitors to the NHS in providing healthcare, research bodies, think tanks. It's going to be a unique resource. And then just a few specifics going back to clinical practice of what seems to be missing to me. Well, the first is we have a crisis in unplanned care. Too many people get into hospital as they deteriorate in the middle of the night. And we're going to build a system that enables the first person you contact to tell you definitively what is available for you locally now. Is it a walk-in center? Is it your own general practice? Is it an emergency department? What's the waiting time if I go to this place now to get it right first time? We're then going to make sure that the first healthcare practitioner our patients talk to has access to enough of their records to enable them to make a definitive decision in one step, and not to be risk averse and pass them all the way along the process until they end up in the hospital. And then we're going to trap the record of that encounter for the next person who sees them. We're going to do something much better than long-term conditions, but I don't know how to do that one. I haven't seen clinical information systems anywhere around the world that join up the care of patients at home with the care of the patient in primary care and the care in secondary care. I don't know if you get there better by putting in a new system or by messaging between the existing systems. But that's one of our big areas we need to work on, and I'm really interested in ideas for how that one can be done. We're going to not lose things that need to be done to patients. So handover within an organization, as you pass from one organization to another, we're going to make sure that that gets really efficient, much better, and uses the right technology for the next practitioner. And we're going to work, as lots of people here are, on the last 5 yards of getting safety and efficiency into those processes. We have some really good opportunities. We have a standard barcoded wristband for inpatients and a standard identification for patients. But all of these projects, we need to just make them routine, so they're not a matter for enthusiasts or something you go and see in a specialist hospital, but that every patient gets these from their bedside. And just a couple of pictures of patients. This is a handheld blood glucose meter. We can use that, and we've installed 200 of these across a hospital in Oxford, with a barcode reader. And the nurse can swipe her staff badge. We have unique staff identification. Swipe the patient's wristband. That's the national standard wristband you see. Measure the blood glucose and make an immediate decision. And when it drops into the docking station, that'll chatter back to the hospital record. And I was using this slide for years before someone pointed out that at the bottom right, there's a pulse oximeter with a digital interface that isn't connected to anything. And then the project I'm proudest of. This is a project about blood transfusion, an expensive, dangerous process. And this is the first slide. This is the before process. We have 2 nurses. They're checking each other's work. There are 37 steps in the process, and they're going to write down the results in the notes afterwards. And by getting control of the technology and working with the staff and re-engineering the process, we can turn that into this: 1 nurse, a handheld wireless computer with barcode scanner, and nothing to be written down. And that is safer and cheaper, the 2 targets I started off with. So those are the things I'd like to connect, but mostly today, I'd like you to connect with us, share your experience on research. We'd like to see new entrants. We'd like to see new investors. We'd like to share our experiences with you. Thank you.